Thank you very much for attending. If we start it formally from now, so this is Hanan. He is one of our scientists at uh, the the Synovus Labs at Guy's St Thomas's King's in central London, and he works on the flow cytometers, and he's giving you a presentation today of a series that we want to do about how we diagnose, and today's one is how we diagnose acute leukemia. So hopefully everyone enjoys that. Thank you, Hanan. Please go ahead.
No problem. So let me know if you can see the screen here. I think that should be okay.
Yes, I can.
Yes. Yeah.
Brilliant. Okay, cool. So, welcome everyone. So, my name is Hanan, and as Yvonne has mentioned, I am a specialist biomedical scientist with just over 6 years of flow cytometry experience. And I've been working at the Synovus Special Haematology laboratory, specifically the Immunophenotyping department at Guy's and St Thomas's Hospital here in London. Just a little bit about our laboratory. So, immunophenotyping section of the Special Heme laboratory primarily does immunophenotyping, diagnostic immunophenotyping of peripheral blood, bone marrow, and miscellaneous fluid samples for patients with suspected or confirmed leukemia and/or lymphoma. So today we'll focus mainly on the leukemia part, but we also do a little bit of other testing and some niche testing as well. So I'll just mention that as well. So we do a little bit of monitoring for monoclonal therapies like rituximab. We do immunological platelet counts. We do platelet glycoprotein flow cytometry, and then some really niche testing, which is Sézary syndrome testing. So as I said, today we'll focus on the acute leukemia diagnosis part, and specifically what part the flow cytometry team here plays in the diagnostic pathway. So a little bit about like the different things that we're going to cover and the objectives. So firstly, I really want to just start by giving a bit of an introduction to flow cytometry. It is a very specialist testing subject. So I just want to be able to have a technical foundation that all of us can sort of like uh, build on and at the very least be able to understand and look at some results and attempt to interpret them. We'll look at some of the principles of flow cytometry, and then we'll try and understand what very specific terms like forward scatter, side scatter refer to, and then we'll try and understand things like antibody binding and why that is crucial for flow cytometry and how that differentiates this from different tests. We'll need to understand all of these terms, especially things like CD markers or clusters of differentiation, what they refer to so that we can look at these dot plots and actually be able to interpret them. And then we'll spend some time looking at, I've picked out two very interesting case studies. And one actually brings together some of the work that the Red Cell Laboratory team has done and probably has shared with you previously, and flow cytometry. So my main sort of priority for the case studies also is to really emphasize the diagnostic pathway and how important it is that you have a multidisciplinary approach when you're trying to diagnose leukemia and lymphoma. And although our laboratory is a small part of that, it is a crucial part. And again, leukemia and lymphoma diagnostics, it's always going to be a multidisciplinary approach. We'll talk a little bit at the end about some diagnostic guidelines and some of that classifications and how things have been changing over the past couple of years. So these are some flow cytometers. They are not very large or extremely extravagant machines. They're actually very small. And I think the first question to sort of answer is what even is flow cytometry? Without making it too technical, because there will be varying levels of sort of experience with laboratory diagnostics here, we'll just touch on it for now. So simply put, I think the most easiest way to say it is that it's a highly accurate and precise single cell analysis method, which allows for cell phenotyping, quantification, and cell enumeration. So in other words, it's a very powerful, time efficient, and universally used diagnostic method across the world by which we can identify different cell populations and quantify them. And in our case specifically, we'll be looking at hematopoietic white blood cells. But flow cytometry can be used in many other situations. For example, red blood cell phenotyping, bacteria phenotyping, virus phenotyping, and even tissue typing. So I think an easier way to maybe sort of think of flow cytometry is, again, think back to your routine laboratory testing. It kind of is a more accurate and precise white blood cell differential in our case. Think full blood counts. But instead of using things like impedance, we're using much more robust lineage-specific identifiers that we call CD markers or clusters of differentiation, which we'll go into a little bit more detail later on. And a good question at this point might be, why even bother with all of this? Because if it's just a sort of glorified full blood count, what's the point? The point, well, is by doing all of the flow cytometry, we can actually accurately assess if patients have hematological malignancies like leukemia or lymphoma, and if the disease is in a chronic or acute state, and even try to figure out the different white cell populations and whether or not they're normal, reactive, malignant, or within normal reference range proportions. So I think here we'll start. So this is going to get a little bit technical, so I'll try and keep an eye on making sure it doesn't get too technical. So to sort of understand what the purpose of flow cytometry is, but now that we've understood what the purpose of flow cytometry is in a diagnostic laboratory, let's actually try and understand what goes on underneath the flow cytometers. So flow cytometers consist of three main parts. The first part being the fluidic system. This allows for a cell suspension, which is prepared separately to flow through to the flow cell. Then you have the optical system, which consists of various lasers and allows us to investigate the cells in this suspension. And then you have the electronic system, which converts the complex data that we gather through the optical system into data we can analyze and interpret. And typically, the workflow for setup and sort of analysis of a flow cytometer for work done on the flow cytometer consists of, you prepare a cell suspension, which is usually taken from peripheral blood samples, bone marrow samples, miscellaneous fluid samples, anything really for our laboratory that contains hematopoietic white blood cells, essentially. You mix them together with an antibody cocktail, you incubate, you lyse the red cells. Now, again, remember, you can do red cell specific assays, but for the purpose of leukemia, we're really interested in white blood cells. So we want to get rid of anything else so that it doesn't interfere. And this entire process of setup can take anything between 30 minutes to 1.5 hours. Now, time of that, the difference in timing here depends on the complexity of the sample, the complexity of the panel that you're setting up. So more complex panels take up a little bit more time. Then the cell suspension is aspirated by the flow cytometer, so you load it onto the analyzer. And it aspirates that into the flow cell through the fluidic system. And each cell flows through it one by one using a special process called hydrodynamic focusing. I've got an animation of that to show here. So I'll just play that as I talk over it. But you can see there is a sheath fluid that's being pumped through a very narrow channel. Then you add your patient sample or your sample suspension, which contains your cells, and this hydrodynamic focusing forces the cells to go through one cell at a time, and they pass in front of a laser at this interrogation point, and the light that they emit is scattered. So once this light is scattered, you've got various detectors that are placed around this sort of interrogation point, and they measure various things. One thing being forward scatter, and we'll talk about that in a lot of detail in the next slide, as well as side scatter, and also the different bursts of light. So every time these cells go through, they emit a burst of light, and these bursts of light are all at different wavelengths depending on what antibody has been added. And these bursts of light are also measured. And all of this data that we're sort of gathering is then converted using the electronic system into something tangible that we can actually look at and interpret in the form of a dot plot. And this data is then analyzed in specific software. We use Kaluza C, but there are many different flow cytometry analysis softwares out there. And any data you generate on a flow cytometer can be interpreted and analyzed in any software that you want. So I've thrown around a couple of very important terms, and I think we should just nail those down. So to wrap our heads around that, we need to be able to understand two terms very, very specifically, one being forward scatter and the other being side scatter. So when I'm talking about all this, I really, really want people to draw parallels to blood film morphology. Morphology and flow cytometry go hand in hand. And if you can draw the parallels from morphology to flow cytometry, you really be able to understand and interpret the results in a very meaningful way. So the term forward scatter refers to specifically the size of the cell. So as the cell passes through the laser, the larger the cell, the longer the laser beam has been interrupted, which allows us to categorize different cells depending on size. So you have small cells, which have a lower expression and signal in the forward scatter. And then you've got larger cells, which will have a much stronger expression and much stronger signal in the forward scatter detector. Next up, we've got side scatter. That looks at the complexity of the cell. So the more intracellular organelles that are present within the cell membrane, the more light is scattered, which allows us to categorize cells by complexity, or often referred to as granularity. So the more granular the cell is, the higher the signal for side scatter. The less granular the cell, the lower the signal for side scatter. So you can redifferentiate out things like red blood cells and lymphocytes from, your neutrophils. And again, I really want to reiterate that draw the parallels to blood film morphology. There are a lot of parallels. And again, if you're able to understand those, then you're going to be able to really understand the data that we're going to be looking at. Next, we need to understand what the purpose of these antibodies are that I've mentioned a handful of times here that we've added to the cell suspension. So antibodies, or another word being conjugated antibodies more accurately, are very, very tiny and have something called fluorochromes attached to them. And these antibodies bind only to very specific target glycoproteins, or epitopes on the cell surface membranes. And we have antibodies that only target glycoproteins on white blood cells. Once bound, this new cell slash antibody structure then is subjected through the flow cell of the flow cytometer. It then passes in front of the laser, and this laser excites these fluorochromes, and they emit bursts of light at different specific wavelengths, as can be seen on the right hand side here. So I'll just play this little animation. I've got another one. So here you can see the binding process. All these floating little things are the antibody with the fluorochromes. They bind to the cell, and then when they pass in front of the laser, they emit these red or green bursts of light, as you can see. These bursts of lights are then detected by the various detectors that we have. And these detectors are very special because they only allow light of very specific wavelengths to pass through their filters. And we can then identify the white blood cells uh, depending on what antibody bound to their cell surface, and we can differentiate things like lymphocytes, monocytes, granulocytes, plasma cells, and for the purposes of leukemia, blast cells. So in our laboratory, we use a Beckman Coulter DX Flex flow cytometer platform. Now, there's many different flow cytometers out there by various different manufacturers. We've been using this one. This has been a very good one, and it consists of up to 13 color channels and allows for 13 color channel analysis for all of our panels. So just to put that into perspective, we have various different panels that we do. The more common one that we do, the one I want to talk about today, is the leukemia panel. That consists of 4 tubes, and in total, it consists of 31 unique antibodies. So you can see how powerful that can be. We can look at 31 different sites on the cells and identify them, and it gives us a lot of information about the phenotype of the cell. Now, you can get some more simpler flow cytometers, like 6 color used to be the norm, then 10 color became the norm, and now you've got 13 colors. And that's within the diagnostic sphere. But within the research sphere, I just want to mention that you can also get something called spectral flow cytometers, and they can allow for crazy things like up to 40 or even more color channel analysis. But here you can see very quickly the 13 channels that we have available, what colors they sort of emit, what lasers are used, and what the name of the fluorochromes are. So you've got FITC, EPE, ECD, APC, all the way down to Pacific Blue, Chrome Orange, and then the ultraviolets. So next up, we've pretty much covered a lot of the technical stuff. So if you were able to keep up, great. So let's get to sort of more the fun part, which is the analysis. So after all this has been analyzed, this is what the data sort of looks like. We call this specifically a dot plot, right? And in order to generate a dot plot in the Kaluza analysis software, you'll need 2 measured parameters on the x-axis and the y-axis. So 1 parameter on each axis. So in this one here, we can see there's something called FSC, which stands for forward scatter, and SSC, which stands for side scatter. And dot plots function by allowing us to look at the relationship between these 2 parameters, right? And just for reference here, just to understand how much data we're actually looking at, each single dot on this dot plot represents a single cell that was analyzed. So in this sample specifically, we acquired approximately 100,000 live cells. So we're actually looking at 100,000 white blood cells in this dot plot, right? So you can start to understand how powerful that can be. Now, by using what we've learned just now about forward scatter and side scatter, we can apply that knowledge here, and we can actually do a bit of a base white cell differential. So thinking again back to morphology, what are we able to identify the different cells here? So you've got three different populations that are separating out. The population that's sitting right down here, it's got low forward scatter and a low side scatter. Thinking back to morphology, that means a population that is small and agranular within the white cell differential. That population would typically represent lymphocytes. Next up, we have the population that sits a little bit higher on the forward scatter and a little bit higher on the side scatter. So again, thinking back to morphology, a population that's larger than lymphocytes and a little bit more granular than lymphocytes would be our monocytes. And then you've got the very large population, which is very granular and very large, and this population would represent granulocytes. And just to mention as well that you can get populations of debris sitting all the way on the left-hand side. Now, these are cells that are very, very small, so these would typically be discarded, so we wouldn't look at populations that are sitting in that sort of area there. So to take it then one step further, we're going to start introducing these antibodies that we added, into the mix at the start. One of the most important plots for leukemia and lymphoma sort of flow cytometry is the side scatter on the y-axis versus CD45 plot. Now, why CD45? So CD45 is a pan-leukocyte or white cell marker, and it's expressed on all maturing white cells. And the most important thing is that the level at which CD45 is expressed depends on how mature the cell is. So the more mature the cell is, the higher it will sit on the scale of CD45, and the more immature the cell is, or the more left shifted the cell is, the further left it will sit on the scale of CD45. So using CD45 and our knowledge about the complexity or granularity of the cells, we can generate this plot and more accurately identify our three white cell populations, or myeloid, lymphoid, and monocytic. But if you were to have certain diseases, like if you had myelodysplasia or something that caused your granulocytes to become agranular or your monocytes to become granulated or larger, you can understand that the previous plot, which looked at side scatter, forward scatter only, wouldn't be appropriate or sufficient to be able to differentiate all these different populations. But with this plot here, we can, right? And the most importantly, specifically for leukemia diagnostics, it allows us to identify blast cells, which can not be identified on the previous plot, right? And the blast cell gate I've just drawn here in the red circle. And just to add, I've added a list of different markers. Now, I'm not going to ask you to remember them. This would be way too much. But just to go over them, myeloid differentiation markers are CD33, CD13, 65, 6060, and 6010. CD10. You've got T cell markers, CD3, CD2, and CD5, maybe CD4 and CD8 you would have come across, especially for HIV diagnostics. B cells would typically express CD19, CD20, NK cells, CD56, and then you've got monocyte markers, CD64, 14, and CD16. So and then I think the most important markers that we're going to be looking at, so in regards to leukemia, once you've identified your blast population, it's going to be your immature cell markers or your progenitor cell markers, right? So once we've identified a population that's sitting within this blast gate, we can then do two crucial analysis steps. So one, we can quantify them. So we can figure out what proportion of the cells that we're looking at represent immature cells, right? Remember the old textbook sayings, 20% plus blasts indicates leukemia. That somewhat holds true. But it's not just as simple as that. I think we'll reiterate that point a little bit later on. And the second thing that we can do is we can figure out the phenotype. So once we've identified the population of blasts, we can then figure out what type of blast they are. Are they myeloid? Are they lymphoid? Are they monocytoid? Are they erythroid? And then we can try to figure out what type of acute leukemia the patient has. Sometimes the percentage of cells of leukemic cells can also be helpful. So if you've got something like 20%, maybe 10% immature cells versus 90%, it can help us assess if it's an aggressive disease that requires immediate treatment or a low-level disease, which can be a little bit more stable and can allow us to safely perform further tests to figure out better treatment options than just sort of first-line treatment. So I think with all of that in mind, we'll move on to a sort of case study. I've got two case studies, and the first one I want to sort of look at is a really interesting one, and this one ties together some of the red cell side of things as well. So it is a 56-year-old female with a known untransfused sickle cell disease, and she presents to the hematology clinic following worsening cytopenias. And the full blood count results that we were able to generate are as follows. So you can see the white cell count is normal, but then she's got the typical sickle cell disease, red cell count being low, hemoglobin being low, and the hematocrit being a little bit low. Now, the most important thing here is that the red cell side of things looks normal, but when you start getting into the white cell differential, and sorry, when I say normal, normal for this patient specifically, because we know she is a sickle cell patient, the white cell differential is where it starts to get really interesting. So as we can see here, the white cell count itself isn't too high, but whether or not that's representative of what's going on with the patient is not really apparent. And when you start doing a manual differential, you can see that you've actually got quite a lot of left shifted cells. So you've got metamyelocytes that are present, you've got myelocytes, promyelocytes, and even some blasts. Now, a really good question to ask is that normal for a sickle cell patient? And the question isn't as straightforward as you think. Sometimes patients that have sickle cell disease, especially when they're in sickle cell crisis, can have a very stressed bone marrow. And as a result, you can have some circulating immature cells. Now, proportions of that obviously are very important. If it's 0.1% or 1% versus 90%, it's very, very different. But in this case, I think one thing that I really want you to understand is that this is an untransfused sickle cell patient that's on hydroxycarbamide, and they are now all of a sudden developing cytopenias, and they have got circulating immature cells, right? So that in itself is not normal, and it's a sort of like thing that you need to consider. And they've got left shifted cells, which is very abnormal. So I think a natural question would be, what other tests would you request? And one of the tests that was requested was a blood film. So a blood film was made, and the following circulating cells are seen. So we've got some blood film morphology. So, you know, one of the main things that sort of like jumps out at you is the red cells, because we know it's a sickle cell patient. Now, I'm not really seeing too many circulating sickle cells, which would indicate that the patient will be in sickle crisis. So the fact that the patient's got these new cytopenias and this left shift is likely not related to the patient's known sickle cell disease. However, what we're seeing is that there are some left shifted red cells as well. So you've got some orthochromatic and polychromatic red cells, and they look a little bit dysplastic as well. But most importantly, you've got these three very, very suspicious looking cells here that indicate that they are sort of, blastoid. Now, they're not massive in proportion, but they are there, and it is a significant feature. So the question then is this normal for a patient with HBSS? So again, to reiterate, if it was a patient with sickle cell disease and sickle crisis, this could be normal. But the fact that this is an untransfused sickle cell patient, the most important features here are the fact that there are no circulating sickle cells and the patient has got some blast cells. So that is worth investigating. So as part of the workup, the patient's blood film was then referred to the hematology doctors for review, and they reported it as follows. So they did the whole report, and I think the thing that I really want to just nail down on is that there's marked NRBC and erythroblasts seen. Majority are markedly dysplastic, and then the other part is that there are a population of large cells of medium to high nuclear to chromatin ratio, open chromatin and nucleoli, and the consultant has queried if these are myeloblasts. So as part of that, again, to ask that question again, is this a normal report for a HBSS patient? And again, if it was a patient that was transfusion dependent, maybe potentially in a sickle crisis, this could be actually okay. But the fact that this is an untransfused patient, we establish that this is not normal. This is not within what we expect for the patient. There's a shift in what normally is seen in this patient, so it warrants further testing. And as part of the testing, urgent bone marrow flow cytometry was requested, along with various other bone marrow tests, specifically your bone marrow morphology, your genetic testing, and some molecular testing as well. Right. So the flow cytometry plots, now these are going to get a little bit technical, so I'll walk you through them. But just remember forward scatter, side scatter, and then side scatter versus CD45, and the different gates that we have. And we have labeled the plots, so they should be a little bit easier to understand. And before we go through the plots, really important to consider, just because there are raised circulating erythroid blasts, it could just simply again mean that this is a stressed marrow. And whether or not there are increased myeloid blasts, that's a very important question. What does that really indicate? Like, at what point are we calling it malignant? Are we not calling it malignant? So the first what we're looking at is CD45 versus side scatter. We've got our different gates here. We've got about 32% granulocytes. We've got about 5% monocytes, and we've got about 30% lymphocytes. But the worrying thing here is that there is a population highlighted in orange and red sitting in that blast gate. And 33%, again, thinking back to like if it's 20%, it's an acute leukemia. This is our first piece of evidence to suggest that actually there is something very wrong with the patient and that it could very well be a sort of leukemia because you've got a significant left shift in this patient when it comes to the blast population, the white cell populations. Next up, we've got our CD34 and CD117. So in the previous slides, I did flash some of the markers, but CD34 is our progenitor cell marker that is expressed in all progenitor cells. CD117 is a marker that is primarily expressed in myeloid progenitor cells. So the fact that on the x-axis you've got CD34, on the y-axis you've got CD117, we've divided up into quadrants. The top right-hand quadrant indicates that the population is positive for both 34 and 117, which indicates that this population is a myeloid progenitor cell population, and we've drawn a gate around it and colored it in orange. So we are able to follow that population along in all the rest of the plots. But the first evidence that we have is there's about 30% circulating immature cells, and they are myeloid in nature because they are CD117 positive. Next up, we have another myeloid marker, which is CD33, and this population in orange. Again, you can see it's in the top right-hand quadrant. It's positive for CD33 and for CD117. Then we have actually a T cell marker. So CD7 is one of the markers that's most commonly aberrantly expressed in myeloid leukemias. Although it's a T cell marker, it can be expressed aberrantly, and that usually is associated with some sort of genetic mutation and usually poor prognosis. So that's quite interesting to be able to identify that. Next up, we've got HLA-DR. HLA-DR is one of those markers that is expressed in a variety of lineages, but HLA-DR is really, really important because it allows us to differentiate the myeloid progenitors, whether or not they're promyelocytes or not, because in things like acute promyelocytic leukemia, your population, malignant population, would typically be HLA-DR negative, whereas in acute myeloid leukemia, it would be HLA-DR positive. So here you can see a bit of a split, which again is quite common. You get a bit of a variation, and heterogeneous sort of expression is quite common in even in leukemias, but also in normal white cell expression. And then we've got CD34 again. So all that then boils down to a technical interpretation, which we reported. So this is the sort of structure of our report that we generate. So we have a very structured report. We go through one population at a time. The first population is the most important population. So for the leukemia panel, that would be our progenitor cell population. We describe the percentage of total nucleated cells. So TNCs stands for total nucleated cells. And then we describe the phenotype. And then we will go through our different populations of granulocytes, monocytes, and then lymphocytes, and then different lymphocyte subsets. So you've got T cells and K cells and B cells. So in this situation, you have a bone marrow sample that has a progenitor cell population that accounts for 30% of total nucleated cells. So again, thinking back to a 20%, this would automatically fall into the acute sort of leukemia category. And then we've described the phenotype. Now that gets a little bit technical, but we use terms like heterogeneous, dim, and aberrant co-expression. But for the most part, what I want you to just be able to remember is that there are progenitor cell markers, and primarily there are myeloid markers. So there you've got CD33 positive, you've got CD117 positive. So those two will be enough to be able to classify this as a myeloid leukemia. And then the different reports that we have for the different granulocyte, monocyte, and lymphocyte subsets. And then to reiterate, so I did initially mention a little bit that leukemia diagnosis happens not just in one laboratory, but it's a multidisciplinary approach. So as part of that, you would want to have an integrated report which looks at the bone marrow and tries to diagnose, as per the guidelines, what type of leukemia the patient has. And in order to do that, you need to pool in all the different testing that has been requested for the bone marrows that have been sent to all the different laboratories, and then look at them all together in a multidisciplinary approach, and then do an integrated report. So flow cytometry is one part of that. The next part of that typically tends to be the bone marrow aspirate morphology. So here you can see a typical sort of, for this specific patient, the report for the bone marrow. So sometimes it can be a little bit difficult because in this case, you can see that on the second line here, adequacy, it was aparticulate, thickly spread in a hemodilute slide. So this would be a big limitation if they were to just try to use the bone marrow morphology to try to interpret or diagnose the patient. They may not get a representative sort of like diagnosis. And even the cellularity, they said that they were unable to assess it. So this is where, you know, it's really important to have a multidisciplinary approach. So in case one sample is either inadequate or there's a limitation of the sample or of the laboratory, that you're not falling short on being able to diagnose the patient. But the main thing in this report here is that they were able to identify an excess of large basophilic blasts with high nuclear to chromatin ratio with cytoplasmic blebbing. And if we think back to the morphology that I showed you, we did see some of those circulating around in the peripheral blood as well. Next part of that typically tends to be that there will be some sort of cytogenetics and molecular testing that is requested. So in this case, the patient had karyotyping done and then was also sent for a myeloid gene panel. And you can see here on the karyotyping, there was actually nothing found. No rearrangements were detected, which is really important because, well, we'll go into that a little bit later on. However, on the myeloid gene panel, they were able to identify a TP53 mutation, and you can see here it is being classified as pathogenic. And all of that information together then is used to generate the integrated report, which is your final diagnosis as per the WHO guidelines. And the final diagnosis for this patient was acute myeloid leukemia, myelodysplasia related AML-MR with a complex karyotype, TP53 mutation, and no other mutations such as FLT3, ITD, FLT3, TKD, MPM1, and IDH mutations were not detected. Right. So that's sort of the pathway that you would diagnose the patient. And depending on the complexity of the case, sometimes it can take a little bit longer, but flow cytometry sort of fits into that. And again, most of these results, they will be discussed in a multidisciplinary sort of meeting, in an MDT meeting, where scientists, doctors will come together, present their data to each other, and then we'll try to come to a consensus agreement as to what the patient's diagnosis is, right? So in order to be able to do that, you need to have a multidisciplinary approach. So case study number 2. So this one's a little bit interesting. So I've just thrown that in here just to reiterate a very specific point, which we'll get to. So this is for an 8-year-old child with no previous medical history. Patient is admitted to the emergency department with sudden onset and progressively worsening joint and bone pain for approximately 1 to 2 weeks. And the patient also presents with fever, significant leg and elbow pain. And the FBC for this patient is as follows. Now, this FBC looks very, very, very normal. The only thing that's sort of weird or has flagged up is the MCV, but that is just slightly outside of range. And most scientists, we were to look at that and say that's irrelevant. The 76 MCV, when the reference range is 77, by itself is not representative of anything. So with pediatrics, it can be a little bit difficult. And that's the point that I really want to like hammer in. So are these results normal for a pediatric patient? I would say yes, they're all within reference range. There's nothing abnormal on the full blood count that has sort of popped up. But would you then request further testing? Now, remember the patient's clinical details. That's where it's really, really important that the patient has been admitted with sudden onset of progressively worsening joint and bone pain. That doesn't just happen out of nowhere, right? So a blood film was prepared just because of the clinical details. The consultants came down and said that they want a blood film and they want a morphology report. And other further tests like chemistry testing was requested. And the blood film morphology looks very, very normal according to this report. So one of the scientists looked at it. They saw some elliptocyte and some rouleau, which again isn't really that crazy or that significant. The white cell morphology, it says that there was mature neutrophils with normal features, some rare large lymphocytes with vacuolated monocytes, no blasts noted or immature granulocytes on the film. Now, on the chemistry, you had CRP and the lactate dehydrogenase. They were both raised. Now, one thing to know, and a lot of people get this sort of, might not have that understanding, that CRP and LDH by themselves are not specific. They're sort of like acute markers and they can be present and raised in many different conditions, including some sort of reactive viral illness or any sort of activated process. So just because you have a raised CRP doesn't immediately mean malignancy, but if you have symptoms and other findings, then the CRP can be indicative that it is some sort of malignancy. And in this case, you've got an LDH that's actually double that of the reference range, and the CRP is high. So with all these results, would you be satisfied? That's a question that a lot of scientists would be asked. I would ask a lot of scientists. You've looked at the full blood count, you've looked at some chemistry results. If you looked at the blood film morphology, would that be enough for you to explain the clinical symptoms? In my opinion, the answer is no. And we wouldn't be able to really diagnose the patient. And that's exactly what the doctors felt. They said, no, something doesn't feel right. So they asked for the blood film to be sent to them, and they did an extensive scan of the blood film. And lo and behold, and they were able to see these cells circulating in very small proportions on the blood film. Now, these cells indicate that there is something that isn't quite right. So they look very aggressive, basophilic, irregularly shaped. And knowing that the patient's an 8-year-old pediatric patient, when you see cells like that, you should be running for the hills. You should be running to the doctors and letting them know that, look what I've seen. This is urgent, right? And these morphologically, I think a lot of people would agree, they look very much like blast cells, maybe even lymphoblasts, right? And that's exactly what the doctors thought as well. They agreed that these look like lymphoblasts, although they're in low proportions. They still wanted to do flow cytometry. So they sent an urgent peripheral blood sample to us for flow cytometry, and the results and the technical interpretation are as follows. So we have, again, your CD45 and side scatter plot. In this case, we've got sort of majority granulocytes, 56%. Then you've got lymphocytes at 36% of total nucleated cells, and your monocytes at 4%. Again, think back to your white cell full blood count differential, right? Very normal proportions. But you've got this small little population, maybe 1 to 2% in this blast region highlighted in orange. And these cells are CD34 positive. Now, they represent 0.18% of total nucleated cells. Very, very tiny population. I think we had something like maybe 100 or 150 total events out of 100,000, right? Very small proportion. But they followed a pattern. They were 34 positive, not 117, so they're not myeloid, but they are progenitor cells. They were HLA-DR positive. They were CD19 positive. So again, if you think back to the slide that I showed before, CD19 is a pan B cell marker. So this population is 34 positive and 19. It's CD10 positive, which is a marker for immature B cells, and then it's CD20 negative. CD20 is a marker for mature B cells. So the more mature your B cells are, they will start to gain CD20 expression, and the more immature they are, they'll be negative for CD20 but positive for CD10. So you can see your population of normal B cells here in blue, and then your population of interest, which is the one in orange over here, right? And then last but not least, you've got confirmation that this is not a myeloid population because we've plotted against CD13, which is a myeloid marker, and it's negative. So we've reported this out as follows. So we said immunophenotyping of PB, which refers to peripheral blood, by flow cytometry has identified a B cell progenitor population, accounting for approximately less than 1% of TNCs, total nucleated cells, with the phenotype is described here, right? So you can see the CD45 expression is moderate, so they are immature, and then 34 positive, 19 positive, HLA-DR positive, 10 positive, right? So it starts to paint a picture, but the proportion is so small. There's less than 1% of these cells sitting in the blast gate. Do you think that explains the full picture? And that's one really, really important thing, because a lot of textbooks will throw around that, oh, if it's 20%, it's leukemia. If it's not 20%, it's not leukemia. That's not necessarily true. And one thing that I really want to reiterate is that for leukemia diagnosis, the diagnosis has to be made on bone marrow. Why is that the case? You need to diagnose the disease at its source. The mutations for leukemia take place in the bone marrow, right? And just because you have some circulating blasts in the peripheral blood, in small proportions, does not mean that the picture will be the exact same in the bone marrow. So you need, in order to diagnose leukemia, you need to do that in the bone marrow. Peripheral blood should only ever be used as an indication or suggestive of disease, but you should confirm it always with bone marrow. And in order to get the full picture, we should look at the bone marrow. And in this case, the consultants agreed that there is a small population, but it's following a pattern. So therefore, we should investigate the bone marrow. And the plots for that patient in the bone marrow paint a very, very different picture. In this case, you can see there is a very large population of almost 81% of total nucleated cells that represents blasts. Okay. And these blasts are majority CD34 positive, following the same pattern in the peripheral blood. They are HLA-DR majority positive, again, following the pattern in the peripheral blood. They are 19 positive, so they are B cell progenitors. They are CD10 positive, but CD20 negative. They are B cell progenitors. And within intracellular, so I won't talk about the intracellular tube too much, but they are TDT positive. So looking at that report, you start to understand that just because in the peripheral blood you saw one thing does not mean the same will be seen in bone marrow. And that's why it's important to use peripheral blood as an indication, but to do the diagnosis, you have to do bone marrow testing. And the report for that then, was reported as follows. You've got CD34 positive, 19 positive, CD20 negative, CD10 positive bright. And the opinion on the bone marrow here would be that you've got a population of progenitor cells that are B cell progenitors predominating almost 80%, 85% of total nucleated cells. And the difference between bone marrow and peripheral blood is that the peripheral blood is the outcome, but the source of the disease is the bone marrow. So we need to make sure we go to the source. So this one was reported at the end as a B lymphoblastic leukemia lymphoma with a specific mutation. So I didn't show the genetic workup, but the sample was also sent for bone marrow morphology, cytogenetics, and molecular testing. And then based on all of that, we were able to get the diagnosis as follows. And the patient was then put onto treatment for that. So I think the last thing that I want to just go over is, sorry, let me just find my way. Yep. The diagnostic sort of like guidelines and the classifications. Now, there's been a bit of a shift in the last, I would say, 10, maybe 15 years in how leukemia and lymphoma diagnosis takes place. Previously, I think the most common classification system that a lot of people will have already heard as well was the French, American, British, or the FAB classifications, which a lot of people were familiar with, M0, M1, M2, as you can see on the left-hand side here, sorry, the FAB classification. However, with time, as treatment has shifted, specifically towards targeted therapies, a need for a different diagnostic sort of classification and guideline arose. And we needed one that was able to keep up with the treatments. And because the targeted therapies discriminate cells based on the presence of specific genetic mutations, the FAB classification system was no longer suitable. And instead, the WHO worked tirelessly over the last, I'd say, 10, 15 years, maybe even longer, towards a more fit for purpose and mutation-based classification system. And who knows, most likely in the future, it seems like treatment will be specifically decided based on what genetic mutations that you have in your malignant population. Now, question then becomes, where does flow cytometry fit into all of this? So flow cytometry still shines through because compared to the molecular and cytogenetic testing, we're still able to rapidly generate results. So some leukemias are time sensitive, and the quicker you're able to diagnose and administer first-line treatment, the better the prognosis can be. Things like acute promyelocytic leukemia, acute monocytic leukemia, and even a pediatric BALL, acute lymphoblastic leukemia. The quicker you can give the treatment, the better the prognosis is for those. And flow cytometry also provides information about lineage. You can also use it to monitor disease, right? So if the patient has been diagnosed and they are on treatment, you can get disease progression or whether or not the disease is stable. You can get information for that from flow cytometry, and the fact that you can build a custom panel for whatever disease you're looking at, and you can check whether or not the patients that have gone into remission are likely to have relapse. So you can do things like MRD analysis, so measurable residual disease analysis, and that seems to be the sort of shift and focus for flow cytometry and the real utility of flow cytometry. And the MRD analysis, but also the rapid turnaround time. So we are able to generate results if we need an urgent sort of like time frame of within 2 to 3 hours of sample collection, in comparison to cytogenetics, which may take 24 hours to 48 hours in specialist labs, but for molecular, that can take days, maybe even weeks, you know? But it's still important to note that leukemia, again, is never diagnosed based on just one method or one finding. It's a multidisciplinary approach, right? And even our results that we generate, our flow cytometry results, before they go out to patient charts, we go through an MDT meeting where us scientists will sit with the hematology consultants and we will present our findings for every single sample that we've processed. And we will discuss those findings and we will correlate those findings with blood film morphology, bone marrow morphology, cytogenetics, histopathology, trephine testing, some molecular testing. And then this approach ensures that we do not misdiagnose the patient, right? We don't miss things. Sometimes you can get, as we saw in the first case, the bone marrow morphology was inadequate, the samples inadequate, the slides that were made were inadequate, they weren't of the best quality. So they underestimated the blast percentage. They had said 12%, but flow cytometry, our sample was good, and we were able to get a much more accurate enumeration. So we said 30%, right? So you can see 12%. The if they had just relied on that, the doctors might have misdiagnosed and said, "Oh, it's starting to get towards leukemia, but it's not quite there yet." So they may not have acted as rashly or as quickly to try to get the patient's results and try them put them onto treatment. Whereas the flow cytometry reiterated, "No, look, it's 30%. There is disease, and it's actually quite a large proportion of it." So you're able to do that. So that's only possible through a multidisciplinary approach. Um, However, having said that, and the shift in the classifications, that just because there's a shift towards the mutation heavy, and you can see that on the right hand side here, you've got all the different leukemias, subtyped into what different mutations they have. But that doesn't mean that the old classification of the Fab is dead. It's still used even in our laboratory, and I would probably think in your laboratories as well, more so to communicate, not to diagnose, but it's very easy for someone to look at a blood film and speak to a doctor and say, "Look, I've seen cells. I think it's an M4," and the doctor will know immediately what you mean by that. So just because the classification system of the Fab is no longer in use doesn't mean you can't use it informally to sort of use the language and communicate within the laboratory and within your multidisciplinary approach to be able to uh, understand what exactly you're looking at. Um, Obviously, the list on the right hand side goes on a lot longer. You've got loads of different leukemias and loads of different mutations. But that is because the targeted treatment nowadays looks specifically at these mutations, discriminates the cancer cells, only allow for better remission rates, patient survival, and effectiveness, right? So I think that's where I'll leave the presentation because I think we covered quite a little bit. But yeah, if we had any questions, then I would sort of ask for them to be asked here. But yeah, thank you so
Yeah,
much.
thank you, Hannah, very
Yeah,
much. There are a couple of people on the call now. Do
okay.
you have any questions? Anyone got any questions? I know that you came in a bit late, so the whole recording will eventually be up on the website. Uh, yeah, but thank you very much, Hanan.
No
That
problem.
was excellent. I hope everyone in Zambia who could make it enjoyed it.